The Black wealth gap is widening. We're discussing real tools and strategies to tackle it. This is about control. Education today to make a real difference tomorrow. Hi, I'm Leslie Batson, host of Black Wealth Empowerment. Today's conversation is one that we had with a long-term friend of mine, Dr. William McDade. For years, I've known him to be a champion for minorities in medicine. Really, I guess is the simplest way I could say it. And we're talking today a topic that really, I think, covers two categories. So you'll see that I'm going to introduce it in the health category, but I do think it also applies to the building and career category because we touch on a lot about the sort of journey, the pathway for a medical student. So if you are a student, a teenager or college student or a parent of a child who's shown interest in being a doctor, this is really a valuable conversation that we've had. But on the health side of this, it is relevant there as well, because the whole point is that we need to have more minority doctors of color graduating and becoming doctors, because they are more likely to go into Black communities to serve and build their practice there. So this conversation gets into both sides of those, but just wanted to do this quick intro to kind of say that this kind of covers two categories, both building and career, and also health. So I hope you enjoy our conversation. Thank you. Hi, welcome back to another episode of Black Wealth Empowerment. I'm your host, Leslie Batson. And today we're joined by one of my good friends, Dr. William McDade, MD and PhD. Hi, Will, how are you?
Hi, Leslie. How are you? Glad to join you.
Thank you for joining me for this really important topic. So as we've been going through this series on Black Wealth Empowerment, we've talked about one of the categories that we want to address in the Black community, and that is our health. So there's several different topics, but today we're going to talk with Dr. McDade specifically around really just the conditions where it affects the medical community, how it partners with, or how it's affected the Black community. So one of the areas that we're going to be talking about today has to do with really the disparities, right, between really the lifespan of people in certain Black communities and how it compares to the number of doctors that service those communities, right? Yeah. So first, let me introduce you, William. So how about you just share a little bit about your background? So when we first met, what was your role? What were you doing at that time?
Well, at that time, I was professor of anesthesia and critical care at the University of Chicago. I was also probably associate dean for multicultural affairs. I went on later to become deputy provost, and then subsequently I became the chief academic officer for the Austin Health System down in New Orleans.
Wow. So you've been doing a lot. You've been doing a lot. So we were recently talking about, your current role, right? So can you share a little bit about what you're doing now?
So I left the Austin Health System and came back to Chicago. My role in Chicago is I'm now the first chief diversity and inclusion officer for the Accreditation Council for Graduate Medical Education. That's the group that in June will be the single group in the country that accredits all of the residencies and most of the fellowships that physicians have to go through in their final stage of training. And it impacts every physician who practices in the United States. The accreditation of those residency programs really ensures the high quality that allows the ACGME to fulfill its mission to improve the health of the public and public health as well. Two different things. The health of the public means that we want to keep you healthy as an individual, but public health means that we want to keep communities healthy. And that's really the important aspect of why I came back to the ACGME. I've been a board member for the ACGME, but to now work at ACGME means that I can focus on the new program requirements. Those are the rules that we ask every program to follow in order to be accredited. And so the new program requirements that I've come to help to establish at ACGME deal with the increase of the diversity and the inclusiveness of the clinical learning environment for all the trainees there. This is vitally important. If you increase the number of people who train as physicians, you actually have to make sure that the environments that they work in are safe for them so they can actually graduate and go out and serve as physicians for the public.
Great. I love this. So I hope, so for those of you who are listening, I hope that you're understanding that this is, a very influential position. And we need it, right? So that what this really means is that we have representation at the levels where these programs have to consider who are going to be the residents, so those medical students who are now looking for that next step to complete their medical education. Dr. McDade, is now going to have some influence, right? He's really setting the standards and how, these doctors, these medical students will go through this program so that they can get to the next level. And I think that it's critical. I think it's really important, because today we don't, I feel, and I don't know, I'm not obviously not in the medical industry, but it feels like there's been, some roadblocks, or maybe it's just been a little bit more difficult for doctors of color to be able to get to that next level.
Well, we formerly referred to the pathway by which physicians go from, grade school to high school to college, into medical school, into residency, as the pipeline. We've stopped using language about pipeline now in deference to our Native American colleagues who have problems with pipelines. And now we refer to it as physician pathway. But if you'll just maintain the metaphor of a pipeline, what we're saying is that we lose trainees who enter the pipeline at every step. Not so many people who want to be doctors when they're in grade school continue what they need to do in order to be successful in college while they're in high school. We lose people who don't go to the right colleges when they leave high school. We lose people who go to college who aren't prepared to deal with the first 2 years and the rigor that goes along with being a new college student and sitting in classes alongside people who may have seen much of this material before, and this is the first time you've seen it, and then you're not as successful as they are, and then you don't make it to the next point with a high enough GPA that will allow you to actually apply for medical school and be successful. We lose people when they apply to medical school. We lose people when they're in medical school. They're not as successful as they could be, and the medical schools find a way to have them leave. And then people who are in medical school have to match into residency programs at the end of their medical school education. And we find that African Americans are almost twice as likely not to match as white counterparts. And then when they get into residency, and this is the end of the pipeline, we find that there are people who graduate from residency programs at the same rate that they enter. And that underrepresented minorities represent a disproportionately large number of those people who don't complete residency. So it is a leaky pipeline. And we not only have to build the pipeline, we have to ensure that we patch the leaks. So that will be the last time I will use the pipeline metaphor, but it really is important in considering the loss of learners all along the pathway.
Yeah, no, thank you for explaining it. So I know that you have some data, right? We can maybe pull up some of your slides, but I think it's really important for people to see it's not just a matter of, oh, we would like to have, more doctors of color. There's actually a true need, and we have data that supports why it's so important to have, whether it's more Black doctors in predominantly Black neighborhoods, or more Latina doctors, or Latinx doctors in Latinx communities. There's actually some data that supports that.
Here, let me share what I have with you.
Okay.
Share here. So this is a community in Chicago showing all the cardiologists, cardiology being probably the greatest need for patients who have heart disease. And if you look at the area that's right where this symbol is here, there's a place called Inglewood. Inglewood has the highest mortality in the city of Chicago. The life expectancy for someone who is born in Inglewood today is 25 to 30 years shorter than people who live in this area in Chicago. And what you'll notice is that there are a lot of cardiologists, blue dots in this area, and in this area adjacent to it, than there are here. And what's the problem with that? Can't people from Inglewood go to the folks over here who are cardiologists, or the folks over here who are cardiologists? And the answer is no, we don't do that. There is a segregation, or a hyper-segregation that exists in society that really portends that people who live in disadvantaged and strongly ethnic communities don't leave those communities to seek medical care. This is data that asks medical students in their very first year whether they plan to primarily work in underserved areas when they finish. So if you look and see who says yes, Black or African American individuals, 60% of them say that this is where they're going to practice once they finish their training. Native Americans, 50%. But you'll notice for Asians, just a little bit over 20% they're here, maybe 30%, and you'll see for whites, again, about that same level. Latinx individuals, 42 or so percent. And that's when they enter medical school. However, if you ask what happens later, now they're fourth-year students and they're asked the same thing, Native Americans, 50% still say they're going to practice in underserved areas. African Americans, 45% say they're going to still practice in underserved areas as well. Asians and whites, 15%, 19%. Mm-hmm. And so what does that mean? That means that people don't want to work in areas where there are poor people in general. If you look at the combined percentage of medical school classes that are white and Asian, it's about 45 and 20% combined. So 66 or 67% of all the people who go to medical school have no intention of working in underserved areas. Mm-hmm. This is data from the Cambridge Health Alliance. And what it shows is the tendency with which a Black doctor sees a Black patient. And you'll see it's 23.24 times greater than the tendency for a white physician to see a Black patient. You'll see the same thing here for Latinx physicians, who have a 19 times greater chance of seeing a Latinx patient than a white physician seeing a Latinx patient. And for Asians, you'll see it's almost 26 times greater. And this means that people tend to choose physicians who are like themselves from a racial and ethnic background. If you look at the primary care physicians alone, a Black physician has almost a 40 times more likely chance of seeing a Black patient than does a white physician. So it's not so much that that I'm telling you that the workforce can't practice where it wants to work, or that I want patients to only see physicians of their same race. That's not the idea at all. It's the idea that this is how we live in American society now. And the proximity is a factor, but it's only a partial factor. The other factor is patient choice. And so when the Commonwealth Fund data was used to look to see whether patients actually chose a physician of their own race, and Somit Saha from the University of Oregon did this, what you'll see is that if you had Black patients who saw Black physicians and you have Black patients who saw non-Black physicians, the likelihood that they chose that Black physician was almost over twice as much than the individual that didn't choose a Black physician. So that when you choose, it's almost twice as likely that you chose that physician because they were Black. Latinx individuals show the same tendency, that if you're a Latinx individual and you chose a Latinx doctor, you have a fourfold chance of having chosen that Latinx doctor because they were Latinx. And if they're speaking language the same as you, that's even higher. So whites don't tend to show that same sort of a difference. They don't have that same preference for choosing a white physician, but most of the physicians are white. And so why do we want to really focus on that? Well, the idea is that people choose physicians of their same race because they have greater trust. There's greater respect for patient well-being by the physician in the way that that patient thinks about the relationship. There's greater communication. There's greater self-advocacy. There's greater attention to adhere to medical advice when there's racially congruent patient and physician relationships. Patient satisfaction's increased. But up until recently, it wasn't sure whether clinical outcomes were going to be improved by racially congruent relationships. And if you look at the data over several years, Lisa Cooper and Neil Poe actually go way back to the 70s to talk about how there's a tendency for Black physicians to take care of Black patients, for Latinx physicians to take care of Latinx patients, for both of them to see more underrepresented minorities in their practices and to see patients who have Medicare. But this is the paper I was telling you about that was done in Oakland, where they looked at males, Black males, they randomized them to Black doctors and white doctors. And what they found is that when Black doctors saw Black patients, that the Black doctors were more likely to get more information about the health of the individual in the encounter. They spent longer time talking. They wrote longer notes based on the encounter. And that when they did this really elegant mathematics with the relationships of the tendency to come back for a follow-up visit, they showed that they could reduce cardiovascular disease mortality and morbidity by almost 20%. And by doing that, they found that Black patients agreed to invasive testing, that is diabetes testing, cholesterol screening, and as well as blood pressure measurement and weight measurement, BMI. They even found that flu shots were increased when there was racially congruent partnership between patients and physicians. And so because of the way we live, because of the trust that is part of the racially congruent relationship, there's a great need to increase the number of people who are of minority backgrounds in medicine. The last thing I'm going to say is that when you make minority physicians, they also tend to go on to faculties and become academically inclined. And what kind of problems do they ask? They ask the questions that deal with health about minority communities disproportionately. So if you want to have people who do research and study how to improve health in minority communities, you have to make more minority academic physicians. And so a workforce that resembles the future patients that you're going to take care of is what we really want to try to drive. I'll drop out of these. The only thing I'm going to show you, though, that may be left is that this. The fact is that the number of people who are in residency programs was represented in the bar graphs here. And we looked at it from 2004, 2005 up to 2017, 18. And what you'll notice when you look at the green bars, which are African Americans, the percentage of African Americans who were in residency was 4.9% in 2004, 2005. It's 4.7% in 2016, 17. Wow. We've actually gone slightly down. Same thing is true for Latinx physicians, 4.8 in 2004, 2005, 5.1, a very modest increase. Now the number has increased slightly because the number of residents have gone up, but the fact is that the percentage has gone down. And we can't afford that if we're trying to make more physicians to have those racially congruent relationships that we've talked about. Let me get out of there.
Wow. This is great information.
Good.
So what are you doing then in your role to help to address this?
Well, so the ACGME has just enacted some new, what we call program requirements. Those are the rules that programs have to engage in order to be accredited by the ACGME. And one of the things that we've asked is for the programs in partnership with the institutions which sponsor them, is that they must engage in practices that focus on a mission-driven, ongoing, systematic recruitment and retention effort of a diverse workforce of residents and fellows, faculty members, senior administrative staff, and other relevant members of the academic community. So what that says is it's a mandate now for residency programs to do something about the disparities. And let me go back to sharing my screen with you one more time. Sure. And show you what the reality is here. Okay. That of the people who go into residency programs right now, there are only about 5,000 African Americans in the country who are trained in core residency programs. These are the ones that you think of. Specialty programs, if you add them, it goes to 6,000, okay? That represents about 4.5% of all doctors are Black in training right now. And if you look at Latinx individuals, about 5.3% of them. Now, relative to the population, about 13% of the population is African American, about 20% now is Latinx. In contrast, Asians represent about 18%, 17% of everybody who's in training. They represent about less than 5% of the population. So there's an overrepresentation of Asians and underrepresentation of Blacks and Latinx physicians, and that's how we live. If you look at the Native American numbers, they're even more startling. Yeah. There are only 242 people who are Native American who are training anywhere in the country right now. If you look at some of the data from medical schools, about 3 years ago, there were only 556 Black men in the entire country who were in first-year medical school classes. Now that's out of a number of about 31,000 people. So if you think about it, it's less than a rounding error in terms of rounding up to the next number. That's where we were with African American men. So there's a great deficit, and we have to be very cognizant of the problem in particular with African American men.
Ooh. So you are addressing what happens when they're, when they need to get to the residency level.
That's right.
If we have parents or young kids today watching this video and they're interested in becoming a doctor, what advice do you have for them? Like, I mean, they might be just figuring out what is my first step to make sure that I can be successful in a career in medicine?
So one of the things that graduate medical education has done heretofore is to say that, well, we don't control the influx of individuals into medical school. We take everybody who comes out of medical school into one of our residencies, and so we really can't control the diversity of the people who go into residency. But that's not entirely true. What happens is people in residencies have been using these surrogate markers to determine what the success would be for individuals they bring in. Some of those are standardized tests, and standardized testing represents a fantastically strong barrier that prevents individuals who are African American and Latinx from entering certain specialties. So for instance, only 3% of everybody who's an orthopedic surgeon is a woman. Less than that is of African American descent. And so if you have an extraordinarily high score that you need on a standardized exam in order to be an orthopedic surgeon, then you're going to limit the number of people who can be orthopedic surgeons. And so the thing that I would do with parents is to really understand how important it is to help your child become a better tester. Now, I think back to my schooling. When I was in high school, I decided I was going to graduate after 3 years in my second year. And so I was actually taking junior English that year because I'd gone to summer school to take an English class in between my first and second year. And so I'm sitting in junior honors English, and the teacher says, is anybody in the class going to take the ACT tomorrow? And I was the only person to raise my hand. And so when I walked up to the teacher afterwards to come and see me afterwards, she said, well, what have you been using to study for the ACT? And I said, well, my older brother, who has about 10 years older than me, had some old SAT study guides around, and that's what I've been using to study. Well, the ACT and the SAT are entirely different tests. And she got this horrific look on her face when I told her that. She reached up into her cabinet shelf and gave me a book on grammar that was very dusty and said, read this tonight before you take the exam. The ACT is a grammar test. So what happens is that you're not prepared to take these exams. And then you end up not going to colleges that are feeders for medical schools. You know that there are 80 colleges in the country that are responsible for about 80% of the medical students in the country. So it's an elite group of universities that actually send people to medical school by and large. And so if you don't get into one of those, it becomes a lot harder for you to get into medical school. And that's how it is today. When you think about the barriers that exist for people to be successful in testing, one, you have to learn how to take tests, but two, you also need a body of knowledge that will help you to be able to answer the questions. And so the poor educational quality that exists in some schools will really be a deterrent to it. But there are opportunities that could be afforded through relationships with graduate medical education programs, residencies, and what we would call STEM programs. That's science, technology, engineering, math, and medicine that exist in many communities. So in Chicago, where I came from, there was a program that's called the Chicago Area Health and Medical Careers Program, CHAMPS. It's now a new program that's been picked up and revived by actual graduates from that program. That now is a big program. It's called the SMASH Academy, and the CPAS Foundation operates it. So there are these STEM programs all around the country and communities, and you can involve your kids in those programs. And what we're trying to do at ACGME is start to build partnerships with those types of programs and the residency programs in their communities. There's a group that accredits medical schools. It's called Liaison Committee on Medical Education, or the LCME. It and its mandates and its requirements asks every medical school to be involved in a pipeline program in its community. And so the undergraduate medical education groups, the medical schools, already have this requirement. I'm now asking the graduate medical programs to have this. And over half of the graduate programs in medicine, the residencies and fellowships, don't have a medical school partner. So that's going to double the number of people who are using medicine as a driver for STEM programs in communities.
Wow. You've already got a game plan.
I think you have to start early. It takes 17 years to make a doctor. So if you don't start early, you won't be able to come up with an end product. And what residency programs do when they see the requirement that I read to you before is they think that we have to outcompete the other residency programs in our area. And that's what I don't want to see. If you spend money to try to recruit a minority resident to your program and keep them away from another program, then you're wasting money as far as I'm concerned. I mean, they can go to either program, it's fine. Use that money to try to reclaim somebody who's been lost in medicine, someone who didn't do well in college because they didn't have good preparation, somebody who didn't think about going to college because they didn't have good education in high school, and they had nobody to tell them that this is the path forward. There are lots of people who could mentor people who are in the medical school pathway, and you just have to identify them through these STEAM programs that would allow that to happen.
Okay, so the one last thing I'll ask you about then is the obvious cost of medical school, of getting a medical degree.
Yeah.
So can you share some of your thoughts if we have some young folks watching this video and they are interested in pursuing medicine. They've now understand that there are, some, there's some help for them, but how do they think about affording this journey?
So medical school is not cheap. There are state schools that are sometimes a little less than the private schools in those same states. The lowest medical school tuition probably is around $29,000 a year. The highest is probably around $70,000 a year. And there are various ways that you can actually get to those medical schools that are more affordable. So I was just having breakfast today with a former student who's now a captain in the U.S. Navy. And the health profession scholarships in the military are certainly one way people can use to get to medical school, through medical school. In the Affordable Care Act, there is a provision to increase the National Health Service Corps. This is a group that's sponsored by the federal government that really sends physicians to health manpower shortage areas, or health profession shortage areas now. And it will pay your way through medical school with the provision that you will go and work in an underserved area when you finish. Well, this isn't hard for many minority students who would do this anyway. A number of medical schools, especially some of the more elite medical schools in the country, have now made the vow that they're going to commit to having zero loans. So Cornell just made an announcement of this to this nature, and Stanford is following to do loan forgiveness for its graduates. New medical schools are sometimes looking to try to increase the number of people who know about the school and its reputation early on. And so the Kaiser School, the Tyson School, Bernard Tyson School in Pasadena, that's going to open this fall, is offering free tuition for the first 5 enrolled classes in their medical school. Wow. So you have to be a little selective about, what opportunities you're going to seek. Aside from that, of course, you can get loans. And the loans that you take for medical school are loans that you can repay. And then the salary that you'll make as a physician, they're generally affordable. It's like having a second house that you never live in. But the fact is that your income is sufficient so that you'll be able to pay off a note like that in a reasonably short period of time. Interest rates are low now, and it probably is the best time. When I was a medical student, they had something called the HEAL loan. And the economy was terrible at the beginning of the Reagan administration. It was 21%. That was worse than a bad credit card on loans. And with a 30-year loan, that represented paying that loan back almost threefold. And so people who got those loans, a number of them defaulted, and that's really unfortunate because that may impact your license. But the fact is that in today's market, today's world, I think people can actually establish loans, keep your credit good during the time that you're in college, during the time that you're in high school. If your parents get a credit card in your name, you may find out about it when you're applying to medical school, and they didn't take good care of your credit. But if your credit is maintained well, and if you maintain your credit well yourself, you'll be able to do it. I will give you some advice that Leon, what's Leon's last name now? I'm blanking on his last name, but Leon was a member, Leon Johnson was a member of the National Medical Fellowships. He sat on their board for many years. And he would give advice to African-American medical students that if you live like a doctor when you're a student, you'll live like a student when you're a doctor, meaning that the interest rates that you pay on the loans that you borrow accumulate, and that you end up using a lot of the funds that you were going to pay, you have to pay to those loan servicing back in the future. So be frugal when you're a medical student, and live on as low means as you possibly can, because you can take out fewer loans you have less to pay back, and compound interest doesn't remove all of your future earnings.
Absolutely. And you're right. If you can, obviously, and that's with any student loan, right? But if you can just live within your means while you're in school, you can celebrate later, right?
It's true. I'll tell you a story of my old roommate. My old roommate, Dr. Giovanni Smith, was an African American who grew up in Viola, Illinois. So a very farm-oriented community in the western part of Illinois. And when we were medical students, we actually had three of us who lived in a one-bedroom apartment. One of us lived in the living room, one of us lived in the dining room, one of us lived in the bedroom. And we shared a kitchen, we shared a bathroom. And Giovanni and I lived together for about 8 years. I was an MD, PhD, and an intern and lived there. Giovanni actually came in his second year of medical school, but stayed through graduation from medical school, then stayed there because he was an internist in a residency program at the University of Illinois, stayed there then, and then he became an attending at the Lakeside VA at Northwestern in his first year after graduating from his residency, and still lived in that one-bedroom apartment where I think we'd gone up to maybe paying $300 a month for rent at that time.
Wow.
He saved up all of his money. He paid back all of his student loans and applied for fellowships the next year and went to his fellowship having paid off all of his medical student loans from having just worked 1 year and devoting most of that salary toward loan servicing as an attending. So you live frugally, you live inexpensively. You don't have to buy a new car just because you get out of residency. And he was able to go into fellowship with a clean slate in terms of his record and in terms of his financing, and could buy a house right after he finished fellowship.
That's great. That is a path that people should be following.
Yeah.
Even for those of you who, or, if you do enter medical school and you do, accumulate loans, there are definitely strategies that I've worked with these, new graduates, new doctors. They do have a lot. I mean, they literally could have a couple hundred or $300,000 in loans,
True.
which seems extremely overwhelming because, just like you mentioned, it's like the cost of a house in some areas of the country.
Yeah.
But they also have a decent salary. And so because of that, we're able to work on strategies to help you get through it. So don't let that be a deterrent, right? If you have a passion to become a doctor or get into the medical field, yes, there are some hurdles, but you can see we have people like Dr. McDade who are in there and they're advocating for you, and they're in positions now of influence where they can really help to change the landscape. We want to see our community, the people in our communities have the same lifespan of those who, in other communities, right? We talk about shortening or squeezing, narrowing this wealth gap. Health is a key piece of it. And so if you are considering medicine as a career, I hope that this has been very valuable to you. If you have questions at all, please, ask away. I can always, tap Dr. McDade and see if we can get some more time with him if you have specific questions. But I really hope that this has been helpful. I know I've learned a lot. Thank you so much, William, for sharing with me.
My pleasure.
Any last points?
Well, I was going to say that what you're doing for the community by running programs like this, I think is really essential, because people really don't understand. There was a website that the Association of American Medical Colleges ran to do exactly what you're doing, disabusing people of the idea that they couldn't pursue medicine because they couldn't afford it. It's called aspiringdocs.org. That site has been taken down now because the AMC did not continue funding it. And to me, that's just shocking. There are all these things that you could decide to spend your money on if you're AMC, but to take that site down strikes me as being one of the poorest decisions that I could imagine ever been made. You got to let people know that they can be successful. You got to let them know that there is a path forward, because there is a path forward, and you have to let people know that they're needed. I think back to one of my former students who came to medical school with the idea of wanting to be an orthopedic surgeon, because there were very few orthopedic surgeons on the south side of Chicago where we are. Mm-hmm. And what we found is that, when he graduated and finished his training, he went out as a practice on the south side and immediately became a huge success. He's a team physician for 5 or 6 high schools. He opened up a practice in the southern suburbs, then expanded to a second office and a third office rapidly. And then he combined with a few of his trainees, fellow trainees in emergency medicine and other disciplines, to establish a set of urgent care centers in the south side of Chicago and in Gary, Indiana, where they were desperately needed. And when you have one person who can make that kind of impact on a community, you see what the importance is of having diversity, serving diverse populations in our society.
Absolutely. And I know that you're far too humble to say this, but I know that this particular doctor might not have been able to get to that point if you had not been advocating for him, right?
Well, it's always important to bring the next generation along.
It is, right? And so thank you for what you do in advocating. And, like I mentioned at the beginning, from the time I've known you, you've been part of these, diversity and inclusion roles, because it's been a very important thing to you to see that happen. So thank you for what you're doing. And obviously you're going to be able to do even more in your current role.
Well, I tell you, it's fabulous when you see people successful. I gave a lecture at the University of Chicago last week, as a matter of fact, and a young woman walks up to me and she says, "You don't remember me, do you?" And I looked at her and she didn't look familiar, but I mean, she had that vague familiarity. And she said, "I was in your Young Scientist Training Program. This is a high school research program that I used to lead when I was at the University of Chicago." She said, "I'm now a second-year medical student at the University of Chicago Pritzker School of Medicine. And my name is Sierra Howard." And to me, hearing those sorts of stories and seeing the success of people who started, very early on, these pipeline programs or pathway programs work. Get your kids into them, sustain it. Let me say one last thing. There's a grant that's run by the National Institutes of Health called Supplements to Enhance Diversity in Health-Related Sciences. If you Google the string PA Papa Alpha 05-015, you can read the request for applications for it. And it's a pathway that allows high school students, people between high school and college students, people between college and graduate school, graduate students and medical students and post-baccalaureates, and even junior faculty to get money from the NIH that they will add into the existing research coffers of people who have certain types of NIH grants to allow you the opportunity to work in those environments. And that's exactly what Sierra got. She was part of a training program that allowed people to work in first-rate labs at excellent institutions. And when you learn in an environment like that, all of a sudden it becomes quite apparent what excellence is. And that's what you strive for. And you don't accept anything less than that as you go forward. And that's how you become really well trained.
I will provide links to all this great information that you've provided, William. I do think that I may bug you again for another discussion because this is great information. People just don't know. I think about, some of the parents who I have as clients. Of course, they would love their children to become doctors, but they just don't know, right? They just don't know. And they don't know that they have the support of, people like you who are advocating on our behalf. So, anyways, okay, so we'll just wrap it up there. So thank you so much. I really appreciate you taking the time, William. And like I said, I will provide the links below. And thank you for joining me.
Thank you very much, Leslie. It's been a pleasure.
Okay, take care.
Bye.
Okay, bye.